9 o'clock, na? I think.
અમીર સર નું બેકગ્રાઉન્ડ જોઈને મને મજા આવી ગઈ.
ક્યાંકથી તો મજા લેવી ને વિશાલ.
अरे बारिश हो रही है वहां पे, केरला, गोवा।
હેવી હેવી હેવી.
बारिश हो रही है।
यहाँ पे गर्मी बढ़ती जा रही है, बीच में बारिश हो गई, उसके बाद आज आज और टेम्परेचर बढ़ गया है.
कल बारिश होने वाली है।
Is it? Let's see.
વિરાટ બરાબર, આપ તમારા બધા પેનલિસ્ટ આવી ગયા?
મારા
બધા આવી ગયા.
પેનલિસ્ટ માં મમતા,
બધા જ આવી ગયા.
વિશાલ, સંદીપ
હા.
ક્યાં છે?
तीखा सराड़ी वाला संदीप नहीं है ना?
જતીન આવી ગયો, સંદીપ નથી દેખાતો.
અને એક્સપર્ટ.
ગુડ ઇવનિંગ મેડમ.
ગુડ ઇવનિંગ સર.
બોલો.
જગદીશ સર, ગુડ ઇવનિંગ.
હા, ગુડ ઇવનિંગ મેડમ.
ગુડ ઇવનિંગ સર.
ગુડ ઇવનિંગ સર. સંદીપે જોઈન.
સંદીપ has joined? Okay. Yeah.
બે એક્સપર્ટ બાકી ને જો આપણે,
આશીષ ભાઈ.
આશીષભાઈ અને શિલા એ
આશીષ
બધા.
ભાઈ ને છે ને બધા.
થોડું માઇટ બી
ખરું
વચ્ચે ડિલે થઈ શકે.
સોરી.
તો આશીષ સર વચ્ચે જોઈન થઈ જશે, પણ વચ્ચે કદાચ થોડું ડિલે થાય.
ઓકે.
શીલા મેડમ ને ફોન કર્યો કુના?
હા, મેં કર્યો તો એમને બધાને રિમાઇન્ડર માટે વાત. સોમશેખર સર નો મેસેજ આવી ગયો તો મહેતા સર શીલા મેડમ ને ફોન કરી દીધો તો.
ઓકે.
એને કીધું તું તો ખરા કે 9 વાગે હું જોઈન થઈ જઈશ. પાછો કરી દઉં ફોન.
યસ, તો પછી આ જોઈન થાય તો પછી સ્ટાર્ટ કરીએ.
આવી ગયા મેડમ થી આ જોઈન.
ગુડ ઇવનિંગ મેડમ.
Good evening.
ગુડ ઇવનિંગ મેડમ.
Good evening.
ગુડ ઇવનિંગ મેડમ.
Good evening.
मैडम गुड इवनिंग।
આઈ થિંક સ્ટાર્ટ કરી દઈએ, વાંધો નહીં.
હા, આપણે 3 મિનિટ પછી સ્ટાર્ટ કરીએ. 9:05 સ્ટાર્ટ કરીએ.
ઓકે.
પલક.
Yes, sir.
9:05 સ્ટાર્ટ કરી દઈએ.
Yes, sir.
વેકેશન મૂડમાં લાગે છે બધા લોકો.
હા, અડધા પાછા બાર હશે.
એવું લાગી રહ્યું છે કરંટ સંખ્યા જોઈએ.
બધાને અમે વેકેશન મળી ગયું ને, હવે કેન્સલ હતું એ.
કેવી પણ ફટાફટ ટિકિટો બધાએ કેન્સલ કરાવી પડી હતી.
Manoj VC sir, our president, Central NNF has also joined.
Okay, great.
Good evening, Manoj sir.
Sir, good evening.
Hi Manoj. Hi Manoj, good evening.
Hi. Good evening. Sorry, I'm
ગુડ ઇવનિંગ સર.
Hi, Vishal. Good evening.
Good evening, sir.
Hi, Biraj.
Hello, sir.
We have to, Biraj, we'll have to discuss the other one later. Huh?
Yes, sir.
Somu
You
sir
see
is
the
back.
mess- I thought you may see it tomorrow morning.
Yeah, Somu sir is back. So, like, no.
Yes.
Like,
I have dropped the message in the group, sir.
I mean, the thing is, I mean, like the group, if I see the message now, it's fine. After some time, there will be 100 messages, and then so I don't check very regularly. That's why I'm
I
missing.
was expecting your reply coming morning only. Today only I have dropped the message in the group.
Okay.
Samir sir, can we start now?
Yes, sir.
It's already 9.5, 9 and 5.
Yes, Palak.
Yes, sir.
We can start.
Yes, sir. Good evening, everyone.
I would like to invite all of you for the AOPG webinar series, that is the Expert Connect. And this is under the AOPG Presidential Action Plan 2025-2026. And right now we are going to do in association with the NNF Gujarat State Chapter. So today basically we gonna have a very nice theme, that is how to deal with the newborn during our office practice, how to handle them, and when we have to refer to the neonatologist. And today we are lucky enough that as a moderator, as an expert and panelist, all of them are the neonatologists. So actually I want to invite Dr. Jagdish Khamar sir to give a welcome speech. He is a president of 2025 AOPG.
Hello.
Dr. Jagdish.
Haji. Hello, good evening, seniors and friends. On the eve of very hot climate, I welcome all of you for AOP webinar series, Expert Connect, under the AOPG Presidential Action Plan. This webinar series highlights us about the neonatal office practice and neonatal cases for how to handle it at a primary level, as such at our levels that we are practicing at the district levels. In this era of test tube babies and very precious neonates and very precious newborn babies, this discussion will help us for various aspects of newborn practice. I welcome uh, I welcome NNF President National Dr. VC Manoj, Dr. Amit Upadhyay, NNF Secretary General Central, respected Dr. Nirmal Choraria sir, that is President of NNF Gujarat, and Dr. Kunal Aiha, that is Secretary of NNF Gujarat. I also welcome Dr. Ashish Mehta, my colleague and mentor, Dr. Sheila Iyer, Dr. Somsekhar Nibarkar sir, and panelist and moderator, Dr. Biraj. Our various web series had got tremendous support from our colleagues, and in future I hope so for same cooperation. Jai AOP, Jai Hind.
Thank you, sir, for the wonderful speech. Now I would like to invite Dr. VC Manoj, sir, who is the President NNF 2025, for the welcome speech.
Respected. Am I audible?
Yeah.
Yeah.
Yes, yes.
Yes, sir. Yes, sir.
Respected seniors and my dear friends. Warm greetings from National Neonatology Forum, India. The National Neonatology Forum, as you all know, has always been at the forefront leading the struggle of the practicing pediatricians and neonatologists to stay updated in knowledge and skills amidst continuously evolving treatment protocols and neonatal care worldwide, as newborn care has progressed in leaps and bounds. Now, from the good old days where we used to merely focus on survival and then later on to intact survival of the tiniest babies, our aim has grown. And now we evolved to a stage where we need to help these children reach their full potential and live adult lives free from lifestyle diseases. We at NNF believe in bridging the gap between science and practice right from the early days of our practice. Mind you, there is a big gap. What we learn and what we teach is not what is being practiced. This gets even more complicated in resource-limited settings. And this is the reason why we should have programs like this. I'm so happy to see AOP Gujarat undertaking to take up this program with this objective in mind. So let me congratulate the whole team Gujarat for this. And I wish all the success for this initiative. I'm sure we are going to have a great discussion today. So I will not take any more of your time. Again, thank you so much for inviting me, and I wish all the success for this program. Thank you.
Thank you, sir. Now I would like to invite Dr. Nirmal Choraria, sir, who is the President 2025 NNF Gujarat, for a welcome speech.
I think Nirmal sir has lost the
Nirmal sir.
connection.
Okay. No issue. Now I would like to invite Dr. Samir Shah, who is a
program, Dr. Sheila Iyer, Dr. Somsekar, Dr. Assis, and panelist and moderator of Viraj. We have to deliver care where we can give the intake survival of the newborn. And we know there are many conditions during the neonatal period when the newborn appears in the pediatrician's clinic. Sometimes it can be just routine benign kind of symptoms or signs, but sometimes we have to pick up some issues. And I'm sure the Viraj and the justice.
Palak, you can continue now.
Yes, sir. Due to some connection issue, we will connect further. Now, I would like to invite Dr. Krunal Ahiya, sir, who is the Honorary Secretary 2025 NNF Gujarat, to give a welcome speech.
Thank you so much. I am very happy to join this program. That is our AOP Gujarat and Gujarat NNF program. That is a collaborative, and I hope that we continue also so that we can reach the far-fetched area, and also our Gujarat National NNF President Dr. Manoj Vishi sir dream to reach the unreached. So thank you for conducting such a program. I welcome Manoj Vishi sir. Thank you, sir, so much, sir, for taking out the time and joining us. Thank you, Khamar sir and Samir sir. I thank you for all the seniors, Somsekhar sir, Sheila Iyer ma'am, Ashish sir will join in a short time. Special thanks to Biraj also that she, in a short notice, was ready to conduct this panel. And welcome to all the panelists, Dr. Jatin, Dr. Mamta, Dr. Sandeep, and Dr. Vishal Goel. I hope the best for this session, and hope that we AOP Gujarat and NNF Gujarat conducts such wonderful programs in near future also. Thank you so much.
Thank you, sir. Now, I would like to invite Dr. Samir Shah, who is a Dynamic Honorary Secretary Aopg Gujarat, to explain the concept about this Xpert Connect and for
Hello. Respected Dr. Jagdish Kumar, President AOP Gujarat, Dr. VC Manoj sir, the President NNF Central, Dr. Nirmal Choradia, President of NNF Gujarat State, Dr. Krunal Ahiya, Secretary NNF, all the expert panel of the today's Dr. Sheila Iyer Madam, Dr. Somasikar Nimbalkar sir, and of course Dr. Ashish Mehta in absence, he will join shortly. With all the panelists, Dr. Jatin Unatkar, Dr. Mamta Patel, Dr. Sandeep Tilwani, and Dr. Vishal Goel. Greetings from the AOP Gujarat, and my sincere thanks to the whole team of the NNF Gujarat for accepting this very conceptualized program what we had started in year 2025 to connect the different experts of the different field with the routine pediatricians who are practicing in the different part of our state, and mainly focusing on our OPD based practice and when to refer right time to give a good intake survival, what the Dr. Manoj sir has just now explained. So this is our basic aim and objective of the Xpert Connect. That is the thing, we are not want to go for a detailed jargon difficult cases, but it's a right time approach to handle our routine cases with the right time handing over to the expert, so that there should be the good intake, not just the only survival. That's what mainly our aim and objective of this thing. After the complete successful of our previous 3 Xpert Connect, with the starting with the adolescent health group, followed by the infectious disease group, and lastly last month with neurology chapter. Today again we are connecting with these neonatal cases, and I am sure that all the expert panelists and our whole team will give us such a insight to the related cases that will help all the audience who is hearing at presently lively, and we have continue with our YouTube recording also, who can hear will get enrich their knowledge related to the neonatal cases. My sincere thanks to each and every participant who is joined today to hear our specially invited doctors from our own state, and that is the basic concept to improvise our own faculty who is really placing in the different place of our state. And we had selected all the faculty and the experts from in such a way that we have to cover our main 5 zone of the Gujarat, along with the experts who may be from the Gujarat or the outside of the Gujarat. So this is in short about our concept of the expert, and my sincere thanks all for joining. Hand over to the Dr. Palak again.
Thank you, sir, for explaining each and everything in a detail. Now, I would like to introduce our moderator, Dr. Biraj Thakkar ma'am. She is a neonatologist at the Akansha Hospital, Anand, Gujarat. She has been worked as a organizing secretary GUJ Neocon 2016, and she has been EB member of NNF also 2018-2020. And in the expert, we have Dr. Sheila Iyer ma'am. She is a former professor and head of a department of pediatric SSC Hospital and Medical College, Vadodara, and she had been a president of Gujarat State Chapter of NNF 2013-2014. Other expert, we have a Dr. Ashish Mehta, sir. He's a director of Urban Newborn Child Center Private Limited, Ahmedabad, and also a director at a NICU, Sterling Hospital, Ahmedabad. And he has been awarded by IMA for excellence in the medical care and awarded in the Times Group as a health icon 2018. Another expert, we have Professor Somsekhar Nimbalkar, who is a professor and head of Department of Neonatology at Bhaikaka University, Gujarat. He is a president-elect 2026 National Neonatal Forum India, and he has reviewed more than 30 plus in national international journals and has received plenty of awards also. And he has more than 100 publications on his name and research also. We all know him. And as a panelist, we have 4 panelists. Dr. Jatin Unatkar. He is from Rajkot. He is a director and consultant neonatologist from the Mahi Newborn Care Center. And he has been EC member of Saurashtra Zone NNF Gujarat 2024 and has been a faculty in the various state, national, and neonatal conference. Another panelist, we have Dr. Mamta Patel. She is a DM neonatologist working in the Nirmal Hospital, Surat, and has a special interest in the preterm care and neonatal ventilation. Another panelist, we have Dr. Sandeep Tilwani, sir. He is an assistant professor of neonatal division of pediatric Bhuj, and has a more than 5 publications in neonatology. And the last but not the least panelist is Dr. Vishal Gohi. He is also fellowship in neonatology he has done, and is a consultant neonatologist at the Urban Newborn Care Center, Ahmedabad. Biraj ma'am, over to you to start the webinar.
Thank you, Dr. Palak, for an introduction. And thank you, AOP Gujarat and NNF Gujarat, for choosing me and my team to present this panel over here. So is the screen visible?
Yes, visible.
Yes, yes, full screen.
Yeah. So today we shall be discussing regarding office neonatology, that is case-based issues, and how to handle and when to refer. I will be trying to cover as much as possible. We'll be discussing somewhere around 5 to 6 cases, and then how to handle and when to refer. Particularly, we'll be sticking to the same taglines which has been given to us. Me with my team, Dr. Vishal Gohil, Dr. Mamta Patel, Dr. Sandeep Talwani, and Dr. Jatin Unarkar. So I shall be starting with the first case, that is yellow dilemma, and that is the commonest thing which we usually see, that is the jaundice. So this was a 20-day-old baby who was a full-term male child who was delivered via normal vaginal delivery. Child birth weight was 3 kg. Child was exclusively breastfed and feeding 8 to 10 times per day. The parents had noticed yellowish discoloration of the eyes and skin, which was persistent, and that was started from day 4 of life. But till 20th day, it is persistent. There is no fever, vomiting, pale stool, or any dark urine. Baby is active, alert, gaining weight properly. The current weight is 3.2 kg, so child has gained somewhere around 200 gram. And on examination, there was icterus up to mid abdomen, and liver was just palpable. So I would like to ask Dr. Vishal that what is the approach while evaluating this kind of a prolonged jaundice in any infant?
Thank you for the question, with Dr. Biraj. So, first of all, we need to know that what you call prolonged jaundice. So, as per if we go with the by definition, if you find that the baby has a jaundice after 2 weeks of the age in case of the term baby and 3 weeks of the age in the preterm baby, then you need to do the blood test, which we are doing routinely, like direct bilirubin level. If it is more than 1 milligram per deciliter, then that we call as a prolonged jaundice. And as per our new recommendation, I think the previous one, which we are following, that if your bilirubin level is more, direct bilirubin level is more than 20% of your total, that one is not currently recommended. So prolonged jaundice means more than 2 weeks of the term baby and more than 3 weeks of the preterm baby. The most important thing is to be remembered in this prolonged jaundice that the neonatal cholestasis is common in 1 in 2500, and we always worry about the biliary atresia, and it is like ratio is around 1 to 14,000, so it is very rare. So that means we need to rule out the other causes like UTI, sepsis, hypothyroidism, IEM. So before jump into the that severe thing, we need to rule out this normal finding, normal scenario, and less this thing. So if we do the clinical assessment, first we need to ask about the feeding pattern. Starting from the birth, does baby is feeding well? Does baby require any NICU admission? Like in the preterm baby, sometime baby end up with a prolonged TP and might be end up with the, jaundice. Stool color and urine color is most important thing to ask when you ask for the prolonged jaundice. And we know that if your stool color is pale color or acholic stool, then it is something triggering. Of course, the dark urine color is also keeping in the mind. The weight gain. If baby has enough weight gain, then most of cases are going to be ruled out, but it cannot completely rule out all the neonatal cholestasis cases. If we think about the red flag sign, of course, the pale stool. The issue with the pale stool is there would be always an observational bias. The parents are always confused that does it pale color stool or yellow color stool? Does it normal or not? So in the market, even in the if you search in the Google, you will get a stool color scale by which they can compare the stool. Dark urine, poor weight gain, and lethargy. These are the main thing we need to rule out. If once you end up with your clinical history and the finding, of course you want to do the some blood investigation. There would be the two type of investigation, tier 1 and tier 2. Tier 1 means you are just going to screen the baby regarding the neonatal cholestasis, and for that we need to do the liver function test, thyroid function test, sometimes the septic screening. Even the viral infection is can lead to the neonatal cholestasis. And once you get anything positive finding, you can advance your investigation from ultrasonography to the liver biopsy. So next slide, Biraj. I think this is a stool color scale you can see on the screen. And again, the approach, I'm not going to into detail, but we can follow one of the this chart before jumping to the diagnosis.
Very nicely explained, Dr. Vishal. Now, Dr. Mamta, can you tell that what are the common causes of prolonged jaundice in a term breastfed infant?
So the breast milk jaundice is the most prevalent one. It's a common type of jaundice in breastfed infant that usually appear after first few days of the life and can persist for several weeks and can last up to 2 to 3 months. It's characterized by unconjugated jaundice. The other common one being infection, any kind of infection, more commonly the urinary tract infection, and the common is torch. CMV is most likely underdetected. That can lead to persistent jaundice beyond the physiological range. We have to search for the extravasated blood. We have to see the birth trauma history and whether any subgaleal bleed or whether a cephal hematoma that can lead to persistent source for the bilirubin. Whether there is a congenital hypothyroidism, whether TSH has been checked or not, we have to look into that also. Many hemolytic diseases, commonest in our area, like G6PD deficiency. The other one being most common is like isoimmunization, whether it is ABO incompatibility or RH incompatibility. Minor blood incompatibility also lead to prolonged undetected jaundice. Cholestatic jaundice is a one known entity, and neonatal hepatitis is the one. Biliary atresia in a good looking baby is a very, very common thing, and we have to rule out this thing very early so we can perform the surgery within first 15 days to save the baby and to have the intact baby survival. The other one is less common, like inherited disease, Alagili or Gilbert, and the downs are also associated with the prolonged jaundice that we have to keep in mind while examining the baby and look for the cause of the prolonged jaundice.
Very nicely narrated. So, how would you differentiate between the breast milk jaundice and the pathological jaundice, Dr. Jatin?
Yes, thank you for the question, ma'am. For breast milk jaundice, as we all know, it is basically a benign condition. Baby is generally on breastfeeding, active and feeding well and gaining weight are the main features of breast milk jaundice. Basically, it is a diagnosis of exclusion. While baby is not taking feeding well, baby is lethargic, taking having less weight gain, poor or faulty other things, and maybe is passing pale color stool or dark urine. These are the features of pathological jaundice. Generally, breast milk jaundice is unconjugated one, and that generally doesn't need any treatment. And pathological jaundice might be unconjugated, but most of them are conjugated and having the there are few causes we need to be ruled out early to save the intake baby.
Yes, Jatin, very well explained. Now, Dr. Sandeep, can you tell that when would you refer such case to a specialist?
Yes. So good evening to all. So whenever we come across a case of prolonged jaundice, the first call we need to take is whether we should keep or manage the child on OPD basis or whether an expert opinion is needed. So I will just highlight certain scenarios where an expert needs to be consulted. So first is if the child on investigation has a conjugated hyperbilirubinemia, that is a direct bilirubin which is more than 1 milligram per deciliter. Second is, as Vishal sir had pointed, the red flag signs, that is a history of pale colored stools or a diaper which is darkly stained, that is a dark colored urine, which needs evaluation for biliary atresia immediately. Also, if the child has poor feeding, lethargy, failure to thrive, or hepatosplenomegaly, in that case, also the child needs further workup, so an expert needs to be consulted. Also, whenever there is the presence of dysmorphic features in the baby or midline defects in which there is a high chance that there may be a syndrome associated. So for that also the child needs to worked up after consulting a specialist. And also whenever there is history of cholestasis in the siblings, so if the previous siblings also have a history of neonatal cholestasis, then you may have certain inherited disorders which are running in the family, like alpha-1 antitrypsin deficiency or familial intrahepatic cholestasis. And last is whenever there is a suspected congenital infection with associated features in the form of cataract, skin rash, purpura, or hepatosplenomegaly. So in all these cases, we need to consider referring to a specialist.
So very nicely explained, Dr. Sandeep. So in short, from this case, what we can conclude is that prolonged jaundice is there whenever the jaundice is there for more than 14 days in term baby and more than 21 days in preterm baby. And commonest cause is for a breastfeeding baby is breastfeeding jaundice, provided child is gaining weight and feeding well. If child is not gaining weight, thriving not well, or not feeding well, you need to suspect something else. And don't forget to check the color of the stool, and don't forget to keep a biliary atresia as one of your diagnosis, which requires early detection and treatment. So you can even keep a stool color card in your OPD and can ask mother to see the comparison among the stool, that whether it's an abnormal color stool or normal color stool. So always don't forget to check for the stool color and urine color, and keep biliary atresia in mind. So coming to the second case, that is the infantile colic case. That is a 3 days old full-term baby who is a breastfed female child brought with the excessive crying. She has been crying daily in the evening for the past 1 week. Each episode lasts around 2 to 3 hours, mostly between 6 to 10 p.m. The cry is high pitched but stops abruptly at time. Parents have tried feeding, rocking, and burping without much success. Baby is otherwise feeding normally, passing urine and stool regularly, and has gained weight since birth. So, looking at the history, it seems to be infantile colic mainly. But what feature in the history would you like to check again, which concerns you? It can be other than something other than colic, Dr. Vishal.
Yeah. So first of all, based on your history, I think looks like a more mimics like with the colic, because the as per history, the baby has a cry a lot in evening time, particularly around 3 hours, 3 days per week, and more than 3 weeks duration. That's signs of the crying. And every time we see the OPD, I always ask mother what you are looking for the baby, because sometimes when the mother is come for the same complaint, she always say that baby is crying a lot as compared to before. That's trigger the alarm in your mind, that does we dealing with do we dealing with the different things or not. So then we need to ask in the detail that does babies cry throughout the day, not just in the evening. Does it is associated with any associated symptom, like for example fever? Then definitely we need to rule out the infective etiology, like commonest one, the otitis media, any infection, in severe case you might end up with a meningitis also. Like if it is vomiting or refusal of feed, we need to rule out the pyloric stenosis, GERD. Second thing, we need to also ask about the stool and everything. Yeah, like for example, abnormal posturing and arching of the back. That means you are dealing with the neurology. So that thing we need to remember. Another thing, we need to ask for the diarrhea. Does baby associated with intermittent diarrhea or not? That might be associated with the family history of the milk allergy. And the most important thing is the weight gain, an overall picture of the baby, that baby is gaining weight or not. If it is not gaining weight, that means you are dealing with something different. And the colic is always the diagnosis of exclusion, not a diagnosis.
Okay, Dr. Chatin, what examination finding would help to rule out the serious causes of excessive crying? Dr. Jatin?
Hello.
Hello, Dr. Jatin. What examination
Yes.
finding would help you to rule out serious causes of excessive crying other than colic?
Yes, ma'am. As Vishal told very cleverly, that clinical examination is very important and history is very important for the complaint of excessive crying. As we are routinely having this complaint for all the babies, we need to rule out what are the genuinely serious complaints of excessive crying, which needs to be pointing towards the diagnosis apart from the colic. So CNS few are the CNS things, few are the GI things, and ear condition we need to rule out. Anterior fontanel bulging might lead to a diagnosis of raised acidity, or we need to rule out meningitis or any other CNS condition. We need to examine abdomen, any testicular torsion or obstructed hernia or intussusception system we need to keep in mind. Otitis media, as Vishal told, we need to rule out by ear examination. It is one of the common most differential for excessive crying. And we need to examine neurological examination of babies, very important to rule out CNS causes. So basically, geriatric, ear, and neurological things we need to keep in mind.
So
From the
yes, Jatin.
Yes, ma'am. We have to keep these points in mind. These are the things we need to keep the diagnosis other than the colic in the mind.
Yeah. So don't forget to look for the genitalias. Head to toe examination, including
Right,
diaper को भी
right.
खोल के check
So,
for the genitalia. Sometimes you may miss the hernia or testicular torsions, and baby was excessively crying.
Neeraj, I want to add one point for the
Yes,
regarding
Vishal.
hernia.
Yes,
The
Vishal.
commonly nowadays people are we are saving more and more preterm baby, and the hernia rate is around 30% the preterm baby. So when you discharge the baby, definitely we need to thoroughly examine at the time of discharge, because sometimes if we miss that one, maybe might end up with the certain complication, particularly obstructed hernia. So at the time of discharge, if it is preterm baby, definitely look for the genitals and hernia. And it is, if you just try to see the baby, you will find at least 3 cases in out of 10 newborn means preterm infant.
Or it may even be possible for the full-term infant. I am a sufferer for the one whose son got obstructed inguinal hernia on Diwali night. So I myself have faced the same thing before my exam. So yeah, it can even happen with the full-term baby, undescended testis, and then it can get obstructed. So definitely don't ever forget to look for the genitals. Okay, fine. So then, assuming all is normal, how would you initially manage and counsel the parents? When will you investigate, Dr. Mamta?
As of now, no established guideline for the management of the colic. Typically, we can explain the parents that colic follows the rule of three. Crying of the baby will begin by the 3 week of age. Crying lasts for at least 3 hours per day, or in many cases more than that also. And episodes occur at least 3 days per week. That we can explain them the crying pattern of the baby. Then we can teach mother and parents some soothing techniques. Most commonly adopted is 5S technique. Like how we will initially manage the excessively crying colicky baby. So what is it? Like swinging the baby gently by jiggle, side position of the baby or stomach position of the baby, sounding like shush, and gently calming, putting the baby into the sleep, letting the baby suckle to the breast or a clean pacifier, and gently swaddling the baby. This will help a lot. Other technique of calming will be like white noise. You are obstructing the outer environmental noise and you are providing the baby smooth, sweet noise. Minimal handling and simulating a car ride is well known in the literature to pacify the colicky baby. This we can teach the mother. Other thing, we should advise the parent to overfeed the don't overfeed the baby. And in some cases, trial of the maternal diet, dairy free diet, if suspecting CMPA, that we can advise.
So if CMPA has been suspected, then maternal dairy-free diet can be advised. So Dr. Acha, okay.
So here I would like to add on for a few seconds. Like in the Western culture, there is one concept: period of purple crying. How they will use for counseling the excessive crying baby parent. What they will like specifically denote by the purple crying. Purple is an acronym. Like they will explain the parents characteristic of the crying, like peak of the crying, when it will come to the peak. Then they will tell that crying is unexpected, and you don't many a time you don't know why baby is crying. R is for resist the soothing. Baby will not stop crying whatever you will do at some places and some time. And though the baby will look like he is or she is having a pain a lot and having some serious systemic effect, it is not like that. It may be long lasting and usually by evening. The word period denotes that it has a beginning and the end. So it's like a 10 pages pamphlet like the thing and DVD that is going on in the Western culture for the counseling of the thing. This we can adopt and we can use for our counseling to the parent of colicky baby. It will
So
help
that
a
the
lot in.
patient would stick to you.
Yeah, yeah.
Otherwise, patient would keep on changing the doctor if you won't explain properly.
What they have this with this purple thing now they have like performed one study over 3 year of time. So what they found like ER visits has reduced to around 30% during the 3 year time if they use this purple crying thing and they'll counsel the parent. That's what that literature denotes.
Okay, great. So counseling is the key in this case.
Yes, definitely.
And when would you like to investigate?
Like when you are feeling like that baby is having some new serious symptoms, fever, rashes, vomiting, a poor weight gain, and it's not stop crying, continuous cry, not limited to the evening period of time, all day crying, any abnormal thing, any serious neurological examination that is a parting follow the normal thing, and no improvement over 2 3 weeks despite the soothing behavioral measure parents are adopting. And when you are suspected reflux or milk allergy, you should investigate thoroughly the babies.
Fine. So in case of suspected milk allergy, so how would you clinically differentiate between the colic and cow's milk protein allergy, that is CMPA, in breastfed baby, Dr. Sandeep?
So, considering today's world where we live in the era of Google, so most of the mothers have access to internet, and they'll search like my baby is crying excessively. So when they search Google, suddenly this CMPA thing pops up. And I had a personal experience. Even my own cousin sister once, she rang me up in the middle of night that her baby was crying excessively, and she had read somewhere in Google that it could be CMPA. So, whenever that question arises, so it is very simple to differentiate clinically CMPA versus a colic. So, essentially, the baby in a colic would be a well baby, and whereas in CMPA, you will be dealing with a sick child. Second is the weight gain in a colic baby would otherwise be well. Like in this case, the case which we are discussing, the child has gained weight, whereas in a CMPA, you will see a poor weight gain. And also, CMPA will not only have excessive crying, there will be other associated symptoms involving other systems like a skin involvement, GI involvement, or a respiratory involvement. So, whenever you have a baby who is having a poor weight gain with multi system involvement and a sick look, in those cases, you have to suspect CMPA. In other cases, mostly you are dealing with a colic. So CMPA, it can be seen in all the three sections. That is either in a baby who is exclusively breastfed, or who is on formula feeds, as well as on the babies who are on cow's milk feeding. Okay, and it is basically nothing but an allergic reaction to the protein which is there, like the whey protein and the casein, which are seen in all the types of milk. So it can be seen in breastfed babies also. Usually, they have a multi-system involvement with a poor weight gain, respiratory issues, GI symptoms in the form of vomiting, diarrhea, or blood in stools, and sometimes skin rashes would be present. And the management would usually include the elimination of the dairy products from the mother's diet. And these babies can be put on some specialized formulas, like extensively hydrolyzed formulas are available in the market. EHF is the short form which we use for them. So they can be given a trial of these formulas, special formulas.
So, in short, if baby is thriving well and feeding well and is crying excessively, most likely you might be dealing with the colic rather than anything else. And in that case, you may try with the probiotics and methicon, and as Dr. Mamta explained, all the soothing technique. But red flags are if there is a systemic symptoms, if the crying is persistent, is unconsolable throughout the day, if weight gain is poor, if cry is abnormal, and one should suspect the CMPA, which should be considered if there are GI or skin symptoms. So that is what was the sum up of this case. And now coming to the case 3, where the child is having a regurgitation. This is a 25 days old full-term male infant who is having a persistent regurgitation, throwing up episodes, and occasionally there was a forceful vomiting too. This child was exclusively breastfed. There was no fever, there was no blood in the vomit. But the weight gain was really poor. It was just 100 grams since birth at the age of 25 days, and there was a mild dehydration, there was a soft abdomen, and no hepatomegaly. So, Dr. Vishal, what would you like to check in the history to differentiate between the reflux, gastroesophageal reflux disease, and pyloric stenosis?
Yeah. So thank you for the question. I think this is again the commonest complaint you are looking in your OPDs, and most of time it is difficult within a 5 minute to differentiate all the things. But if you ask the thorough history, you definitely differentiate the major thing from the minor thing. For example, like GER is a very common thing, gastroesophageal reflux, 1 in 300 in the newborn baby, and it is self-limiting condition, and most of the time baby is growing well. So if we start with the history, like when would be the onset? So in case of GER and GRD, it may be start from the birth. In case of the pylostenosis, most of time it start after 3 to 4 weeks of the age. That is one of the important point has to be remember. Second thing is vomiting. So if you ask about the vomiting, most of time it is non-projectile and non-bilious in case of the GERD and GER. But in case of the pylostenosis, the first would be the sudden onset vomiting, which is projectile and non-bilious. That is a key sign for the pylostenosis. When you ask for the associated symptom, of course, in GR, there would be baby's healthy weight gain is there. But in case of the GRD, baby might have a poor weight gain, not weight loss. Just remember poor weight gain and irritability because baby has so much irritation, because of the esophagitis, baby is always irritable, feeding difficulty and arching. In case of the pylostenosis, the weight loss is there because till 3 weeks, baby is gaining weight, but suddenly the vomiting is start and baby might end up with the weight loss followed by dehydration and the lethargy. And sometimes it associated with the respiratory symptom in case of the GERD, like repeated because of the regurgitation, baby might end up with a recurrent upper respiratory tract infection, apnea, wheezing, and cough. In case of the pyloric maybe you might get the respiratory symptom. So key point for the GERD is poor weight gain, irritability, and respiratory symptom. In case of the pyloric the onset is 3 to 4 weeks of the age, projectile non-bilious vomiting, sudden in onset, and the weight loss is there, followed by dehydration and lethargy.
Very nicely explained, Vishal. So now, Dr. Mamta, what are the clinical signs indicating referral?
So when the baby is facing the very, very severe symptoms like frequent vomiting, which are very forceful, projectile vomiting, baby is facing the issue of dehydration. When these episodes of vomiting and regurgitation leads to several complications like respiratory symptoms like choking, wheezing, stridor, apnea, or baby is vomiting blood. Other are the red flags where you should think of the alternative diagnosis. What are the symptoms like weight loss, lethargy, fever, excessive irritability, which are suggestive of a variety of conditions, including the serious systemic infections, bilious vomiting, regarded as a symptom of intestinal obstruction. Possible causes for that could be a Hirschsprung, maybe a intestinal atresia, maybe a midgut volvulus or intussusception. Baby is having the abdominal distension, indicative of obstruction, dysmotility, or any serious anatomical abnormality. And persistent forceful vomiting, which is very much indicative of HPS, hypertrophic pyloric stenosis, up to the infant age 2 months. That all are the indications that we should refer the baby to the higher center for the investigations. Thank you.
So what investigations would you advise to send, and mention their role, Dr. Jatin? Dr. Jatin?
Yes, am I audible, ma'am? Hello?
Yes, Jatin. Yes, Jatin.
Yes, yes. Yes, X-ray we need to get it done, ma'am, to rule out air fluid levels, any sign of intestinal obstruction is there or not. As discussed earlier, pyloric stenosis is one of the strong probabilities when there is vomiting. So we need to rule out by ultrasound abdomen and classical electrolyte and ABG abnormality of hypokalemic, hypochloremic metabolic alkalosis. So ABGA, X-ray, edema and barium follow through to rule out obstruction upper GI or lower GI or maybe malrotation. Especially before jumping into the investigation, definitely as Vishal, clinical examination, detailed history, feeding patterns, weight patterns, and vomiting patterns needs to be analyzed properly because most of them are picked up on a clinical ground only without investigation.
Nice, Jatin. So, Dr. Sandeep, how baby is to be managed in office, and when baby is advised to be referred, the one who is having a excessive throwing up episodes?
So as far as OPD management is concerned, the first thing is that we need to first relieve the parents' anxiety. Second is that the baby has to be fed in an upright position, which helps to keep the milk in the stomach. Once the child has been fed, we have to encourage the parents to birth the child properly, so that whatever the swallowed air is there or trapped air is there, it gets released. And after that, we have to ask them to avoid overfeeding, because and we should teach the mother that she has to give frequent but small volume feeds frequently. And also, after feeding, the child has to be kept in an upright position for at least 30 minutes after the feeding. uh, there is an option of using the thicker formulas in the literature, but they are not directly available in the Indian market as of now. But yes, that is an option if we could arrange it from somewhere. But I mean, it is not directly available in the Indian market as of now.
Fine. So in our case, where we were suspecting gastroesophageal reflux disease because child weight gain was poor, it was only 100 gram from 25 days, and rest other systemic examinations were if fine, other than the poor weight gains. Then in that case, you can just try all these measures to avoid the reflux, and then if nothing works, then you can finally consider the thickened formula. And situations
And
when the
situations,
referral admission needs to be considered.
yes. So whenever there is failure to thrive, or the child is looking dehydrated, or whenever there is abdominal distension or suspected lower GI obstruction, suspected pyloric stenosis, or a bilious vomiting or a blood-stained vomiting.
Fine. So here the weight gain is again the key mantra for any most of the condition in neonatology. It's our main key mantra is baby is thriving well or not. If child who is gaining weight is definitely going to be okay, even if child is throwing, even if child is crying. But and GR is a quite physiological thing, and it can be there till even 12 months. But red flags are if there is poor weight gain, if there is a bilious or projectile vomiting, then in that case you should investigate and refer timely. Coming to the case 3, where there was a feeding issues with this 5-day-old term infant who delivered vaginally with a weight of 2.9 kg. This mother complains pain during breastfeeding and the baby cries often after feed. The infant appears fussy, feeds every 3 to 4 hours for 10 to 15 minutes only, and weight now is 2.65 grams. 2 kg 650 grams, which is 9% of the weight loss since the birth, and maternal nipple appears cracked, flat, and breasts are engorged. So, Dr. Mamta, how would you approach the evaluation of the breastfeeding in this infant?
So I would like to start with the history of the feeding, like what is the frequency, how is the duration. Duration may vary for baby to baby, and we should teach as well as evaluate whether mother is knowing the cue-based feeding. We should. This slide is showing one picture like baby feeding cues. That while taking history, also we can teach the mother regarding that, like what are the early cues at that time you should address the feeding, what are the mid cues that baby is showing I'm really hungry, you need to address my hunger. And the late cues when baby is very cranky, first you have to pacify and soothe the baby, and then only you can feed the baby. Like that simultaneously history and counseling can go hand in hand. Then we should examine the baby and we should examine the mother also. Baby for what? Baby for whether any tongue tie, whether cleft palate, whether any anatomical abnormality that would block the normal breastfeeding experience, that we have to identify. We have to check for the sucking reflex. Then examine the mother for nipple anatomy. Examine the mother's breast fully for engorgement or M, as well as you should like extract the mother's psychology and level of confidence also. One of the subjective criteria and subjective format to assess the breastfeeding is latch score. So this is the component of the latch score. L stands for latch. Like how baby is latching. Then A stands for audible swallowing. T for the type of nipple. C, comfort of the mother as well as the mother's breast condition. What are how the things are obscuring the breastfeeding that we have to identify, and whether mother is requiring help during the breastfeeding. So this is a structure format. We can see the 0, 1 and 2 approximately around 5 object and up to 2 points. So 10 is the maximum score. And I would like to examine our baby for the breastfeeding. So we have to actually make a practice in our OPD setting also, whether we can observe the breastfeeding with the male pediatrician or neonatologist can take a help from the staff or nurse. And I think we should teach our nurse also whether they can put the latch code. That is very beneficial. We can like we can before discharge also we can identify the latch is very important thing. It can predict the duration of the exclusive breastfeeding in the many mothers, and we can like identify the problem very early and sort it out. So in our baby I have I want to and I would examine the breastfeeding. And as far as like baby is fussy and weight loss is also there, mother nipple is cracked, I have to see for the latch also, like how the baby is latching, whether mouth is widely open or not, that lower lip is everted, baby's chin touching the breast, and areola, especially the lower areola, should be inside the baby's mouth. So these are the few technical point about latching. How is the baby's position, whether baby is in supine, fully supported, right, the torso is in one line, and that also should be checked. And then the audible swallowing and that full leg score I want to put for our baby. Here some maternal issues are there, maybe due to latch, maybe due to some other reason. So I think for our baby I want to put latch score, and if it is coming above 7, this is the common norm, that latch score is coming above below 7, sorry, below 7, then you have to assist the mother. You have to identify by putting the score on itself, you can identify the problem and help mother. That would sufficient for the thing. I think I would do the same.
Okay, so it was nice to observe the breastfeeding in the OPD and put it at the LESH score, and then be it objective rather than being a subjective, to find out whether the mother is in need of help or not, and what are the actual issue while breastfeeding the child. Now, what what support or interventions can help with the poor latch and maternal pain, Dr. Sandeep?
Yes. So, as Dr. Mamta had pointed out previously, we have to first assess whether she is attaching the baby properly to her breast or not, and whether the position is correct. So, we have to look for the signs of good attachment. Once we have done that, we need to explain to the mother the various positions in which she can hold the baby and breastfeed. So, these are the four positions which can be seen in the figure. So one is the cradle position, one is the cross cradle position, one is football position or sideline position. Now there is no ideal position. I mean, it is as per the mother's comfort, whichever position she feels comfortable. She just has to be shown all the positions, and whichever position she feels comfortable, she has to be encouraged to feed. Once we have done that, the next thing is we need to look for a flat nipple or an inverted nipple, and if so, then we have to help her with the syringing to extract the to pull the nipple out. And if she is having a cracked nipple or a sore nipple, as is there in this case, then in that case she can be encouraged to use a nipple shield, because that will decrease the pain or this thing soreness during the feeding. Okay. Next. And so these are also the other options which are available. So we can encourage the mother that if she is having a sore nipple, then in that case she can apply the hind milk. Once she finishes the feeding, the hind milk which is left or which is coming, she can apply it to the nipple. She can also take the help of some barrier creams like lanolin, which may be helpful. She can use a hot or a cold compress, and she should be encouraged to keep the nipple dry as much as possible. And she can use the breast shields and massage the engorged breast, and she has to be told very clearly that soap has to be avoided. So these are some of the interventions which would help her with the cracked nipple or sore nipple.
So commonest advice being given is for the sore nipple is कि घी लगाए क्या doctor साहब? So what would you like to advise to your patient?
It can be anything which acts as a soothing agent for the mother or helps to moisture it will do the same job of a barrier cream, I feel. So if she's or rather she can be encouraged that if she is having good milk secretion, she can just apply the hind milk. So that is more easier or safer, I think, to apply.
Okay.
And if it is causing a lot of pain or bleeding, then maybe she can be explained about the breast milk expression either manually or by a pump, and then that same milk can be fed to the baby by a katori spoon.
Yeah, because this part of counseling and is really requires time and patience, and that all only is needed in such kind of a cases. Then when should supplementation be considered in such cases, Dr. Vishal?
I think it's one of the difficult question to answer, when it's a big boss in the, like Sila madam is always the things that don't give the supplement feeding. Of course, there is a few exceptional, like if baby has a weight loss exceed more than 10% signs of dehydration, of course, we need to do something for the baby. And I always tell in the OPD that your baby is looking fine. Baby has a weight loss because of only two reasons. Either your baby is not getting enough milk or either your baby is sick. Okay. So 99% cases, always the feeding is the issue. So if baby has a mother has a issue with the latching, but baby is getting enough, a mother is getting enough milk, then of course you can express the milk and you can give by a katori spoon or either in the paladi if possible. Of course, the donor's milk is option in one of the cities. You can offer that one also, apart from the the formula milk. And if it is still not available, then we do have a formula at end. Of course, avoid the bottle to prevent the nipple confusion as well as the infection. And in between that, definitely we need to, continue doing exercise regarding the excessive breastfeeding efforts. If lactation support is available, of course, take advantage of that one. That's it.
And when would you refer this baby or mother to the specialist, Dr. Jatin? Jatin is, I think, network issue. It always take a little while for
Yes.
connection.
Yes.
Yeah.
Hello. Yeah,
Yeah.
ma'am. Yes, I'm sorry. If we on examination, if we find baby is having genuine issue apart from the issue, or maybe only attachment issue, if we find baby is lethargic, or if baby looks dehydrated, like in our case, or baby looks jaundice, then we need to send baby to consultant or maybe in NICU for admission to rule out pathological causes of not taking feeds well. If baby is looking okay and only latch issue is persistent despite proper support to the baby, we need to consider tongue tie, and we might need pediatric surgeon or ENT surgeon to address that issue if it is genuinely causing the problem. In case, when should we refer the mother? When mastitis is there, mother is having engorgement followed by abscess formation or severe nipple trauma by repeated abnormal position of an attachment of the baby, mother might need to be referred to a gynecologist or maybe a surgeon.
Yeah. Thank you, Dr. Jatin. So, in short, in such kind of a cases, we have to have observation. We need to stand beside the mother while she is feeding the child, and we need to actually observe how the child is taking feed, how the child is latching at mother's breast, whether it's sufficient or not. And counseling is the key. So always counsel the mother properly, and thorough examination of mother's breast as well as baby's mouth. There might be sometimes a tongue tie or lip tie which is hampering the sucking and causing the problem. So don't ever forget to check for the tongue tie or lip tie in cases of poor latch for the baby, and always examine mother's breast and refer when there is a mastitis. Think aggressively and act aggressively when there's a poor weight gain or lethargy. And coming to fifth case, that is seizures versus jitteriness. This is a 4-day-old term male newborn. who was delivered normally vaginally and was having a complaint of intermittent shaking of the limbs, mostly when the baby is crying or during handling. The movements are symmetrical, involves upper limbs more, and are not associated with eye deviation, apnea, or altered consciousness. Feeding is adequate, urine and stool pattern are normal. There was no resuscitation at the time of birth, and there was no maternal history of gestational diabetes or substance abuse. The child is afebrile, was alert in between the episodes, and has normal tone and reflexes. So, this is most likely to be a jitteriness against the seizures. So, how do you clinically differentiate neonatal jitteriness from the seizures in outpatient settings, Dr. Vishal?
Yeah, so basically, this is the again the commonest neurological finding you might encounter in your OPD, the jitteriness versus seizure. And of course, it is easy to identify which one is a seizure and jitteriness. First of all, the does it provoked by the stimulation like touch or light? That means that you are dealing with the jitteriness, which in not in case of the seizure. If there is a tremors or high frequency energetic movement, that might be the jitteriness. In case of the seizure, you might see the clonic tonic movement or either subtle seizure. The one key point is the eye deviation, which is absent in case of the jitteriness and common in the seizure. Second thing, the autonomic changes are absent in case of jitteriness, but it might present with the seizures like apnea, tachycardia, desaturation. Baby might end up with the respiratory distress or depression. And the another key point is it can be stopped by holding the limb in case of the jitteriness, which in not in case of the seizure. And the alertness post event would be normal in case of the jitteriness, may be altered in the seizure. So key point would be the eye deviation, autonomic changes, and jitteriness is can be stopped by holding the limb.
So, what are the common causes of jitteriness in neonatal seizures in term babies? Jatin.
Yes, ma'am. As we all know, that transient metabolic disturbances are commonest reason. Transient hypoglycemia, transient hypocalcemia are one of few commonest reason for jitteriness, which are often easily treatable. We need to rule out those conditions. Maternal medications like SSRIs for maternal psychosis, and as Vishal told, commonest would be the immature nervous system, so it can be considered normal up to few weeks of life, 2 to 3 weeks of life. Jitteriness is benign, and it needs no attention. While as we all know, neonatal seizures, commonest reason would be hypoxic ischemic encephalopathy, followed by intracranial hemorrhage. Transient metabolic disturbances like hypoglycemia, hypocalcemia, hypomagnesemia can lead to neonatal seizure. Uh, Cerebral infection, meningitis, and TORS infections, and inborn error of metabolism. These few are the conditions which will lead to neonatal presentation of seizure. Commonest would be of HIV, and as Vishal told, jitteriness would be commonly manifested in a normal baby.
Thank you, Jatin. So, Dr. Sandeep, which investigations are essential for evaluation of such neonate in the office or the OPD setting?
Yes. Whenever a child presents to our OPD with abnormal movements, first and foremost, we need to go for a detailed neurological examination as much as possible, and the assessment of the head circumference. We need to have a quick look for the dysmorphic features, if at all they are present. Then, if everything is normal, to proceed, we should go for a basic metabolic workup, which may include the blood glucose, calcium, and electrolytes, and also so it may include the blood glucose, calcium, electrolytes, and serum magnesium and sodium levels. If that is normal, then we may proceed for infection workup, which includes a sepsis screen, a CRP, and also we need to go for a torch serology if it is clinically indicated. If there are other features which are pointing towards a torch infection, then we need to go for a torch screening. Then cranial ultrasound or neuroimaging is only indicated if there is a presence of an altered sensorium, or there are unprovoked movements, or the movements are not ceasing with restriction, or there is an abnormal gaze. So these are the pointers towards pointing more towards seizures. And if there is multi-system involvement with previous sibling deaths or a strong suspicion of an inborn error of metabolism, then we need to consider the second line metabolic investigations like ammonia, lactate, ketones, and ABGA to rule out inborn error of metabolism.
So, Dr. Mamta, how would you manage jitteriness and when should a baby to be referred to a higher center?
So if we are finding its physiological and transient phenomenon of the abnormal movement that is called jitteriness, we should reassure the parent and correct the underlying cause. We have to check for the glucose. If hypoglycemia is there, whether IV or oral glucose, IV calcium gluconate slowly with the proper cardiac monitoring in case of we are finding hypocalcemia. In case of the drug withdrawal of the baby, we initially the supportive treatment will be okay, and like swaddling, decreasing the stimulation, small frequent feeding, that would be okay. In some cases intravenous fluid and electrolyte may be indicated. The decision of the like using the drug depends on how are the symptoms and how severe are the symptoms, that require in the few cases only. And the most important thing, we have to educate the parent when to seek the help, like episodes of apnea, cyanosis, eye deviation, any automation like described previously. We have to educate the parent in that those cases they have to consult the doctors. So what are the referral criteria? The same thing, like unprovoked movement, suspected seizure, failure to thrive or poor feeding, abnormal neurological examination, and recurrent and worsening episode over the period of time, they should we should refer the baby to the higher thing.
Fine. So, like, if it is a seizures, we should have something which help us out to differentiate. You can tell parents to take a video and can have a look at it. So, this is the kind of a video. This is a right focal seizures, and this definitely requires treatment and referral. This is not a benign condition. But against that, this is a multifocal. This probably video is not available, but that also requires treatment. But this is a benign condition. This is a benign nystagmus. So kind observation, and always ask parents to take video. If they explain some movements, it is always good to have a look at the video and can judge whether it's a normal or benign condition or something which requires investigation to be done. And this is a benign slip myoclonus. Again, this doesn't require any treatment. So in summary, the jitteriness is common in newborn and it is often benign. Important is to distinguish it from the seizures through the detailed history and examination, as all the panelists described. And always check the glucose, calcium, and correct the metabolic abnormalities. And refer urgently if seizures are suspected or baby is symptomatic. Can anyone tell what is this? Suppose if you have a baby who comes to you in OPD in the status, who has a seizures. So what is this? So this is basically a midazolam spray. You can keep it in your OPD or the emergency room where the patient comes in the convulsing state. You can put it in the nostrils and as an emergency medications before referring the child to the higher center. So this is a midazolam nasal spray. And here I am ending. I would like to thank all my panelists and all the audience, and we are open for the questions.
Thank you, ma'am, for the excellent session.
Can we having a expert comment also? From the doctors Hilayar madam and Dr. Somasekar sir.
Thank you, Samir bhai. I patiently listened to all the cases, and I would like to comment that I think they have been well discussed. I think so. In the last case, not the last case, the last but previous, the breastfeeding related case, which is quite common, and Dr. Vishal mentioned that it is often many times we get people who get additional feeds when they are not necessary. So I think most commonly, I think there is a issue with patients both on pediatrician side as well as parent side, and there is a rush to kind of give increased feeding immediately from outside, which is a problem. And this is especially a problem if it is a term baby. So I think we should be very careful in assessing when it's a term baby. But when it's a preterm baby and there are issues, especially in the NICU supply, I think then we should be not very strict with supplementation. We can be using proper formulas, etc. So I think we should be having good balance on both the sides. And many times people who are very, what do you say, strict with supplementation often avoid giving feeds or enough nutrition for preterm babies, which can be also damaging. So there are both sides of the coin. But a regular normal term baby who's feeding well, I think there you can actually wait. Many times I've had asked patient come maybe 2 times or 3 times in a week just for weight check to see if there is a good weight gain that is happening or not. And if you're patient, your patients do improve, but that is needed on both the side of the patient as well as the doctor. Increasingly, there are a lot of patients who don't like getting supplementation because of ChatGPT and Google, and if you often advise formulas, they are likely to not accept it. So you have to be very careful while giving formulas. In terms of the abdominal pain case, which was there, the one which there is pain and colic, which was there. Well explained as to how to take measures, but one of the most important reasons, while I don't remember it getting discussed, but anxiety in the parents because of the baby crying also increases anxiety in the baby. So I think it's very important to treat the parents. So the Cymethicone, etc., what is given is actually not treating the baby's colic, but treating the mother's anxiety or the parent's anxiety. So we have to understand, and I think explaining to the parents that anxiety plays a very important role in increasing the colic or decreasing the ability to calm the baby, I think also helps improve the colic pain. And if you tell them that this is a common thing, many people have it, it will go off, shouldn't be a problem. The regurgitation is very common actually, and while the 1 in 300, but we see quite a few patients in OPDs, and so you are likely to see many regurgitation patients. We really don't see so many GRD patients, and as always, weight gain becomes the most important factor. If there is a good weight gain, we really have to worry less and less about. So in general, if the patient is exclusively breastfeeding, having good weight gain, many of the issues that happen are actually not a problem at all. This thing about uh, crying baby, and this particular case was kind of a prolonged crying every day, evening, specific timing. But we do get babies who are like between like 2 weeks to 6 weeks or old, crying which is continuously occurring and not like stopping or coming every day. So in those cases, there might be surgical causes. Long time I had a patient who was referred for crying for 2 days. No one had opened the diaper, and there was a hernia which it was obviously red, which no one noticed, which got operated and baby improved immediately. So there are ensuring that you do good clinical examination will give you more information than investigations. Again, for the pyloric stenosis, mostly I think it's ultrasound, which is quite diagnostic nowadays, and people wouldn't do X-rays. So that would also kind of help improve the care. I think those are comments overall from all the more or less. I think it's getting quite late, and so maybe Dr. Sheila, if she wants to say something.
Yes, we had a good discussion in some of these
Yes,
common cases where we do require to give more time to the patient. One thing which I wanted to add it in the prolonged jaundice. Prolonged jaundice for breast milk, which one has to remember is always going to be unconjugated. So your biliary atresia and other things would go towards conjugated. Another thing, it's non-hemolytic. So your hemoglobin and PCV are normal. You have a normal retic, and you have a normal thyroid function and a normal G6PD estimate. Then probably reasonably you can be sure that what you are dealing a healthy child gaining weight, but it is breast milk associated jaundice. And not breastfeeding associated jaundice, you see in the first few days when the feeding inadequacy actually leads to little more weight loss and you see jaundice. So I agree, breast milk jaundice is diagnosis by exclusion. We should not hurry up on putting that as a diagnosis and trying to give that withdrawal of 48 hours and proving it. And most of the time it doesn't go very high level, though reported incidence of 20 or 21 milligrams also have been reported. So that was regarding, I think, what, and as I think Dr. Somshekhar pointed out, I think feeding issues needs a lot of support from all the sides, because these days many mothers not properly latching, early supplementation and lactation failures we do see. So probably from the time of delivery, discharge, and the first visit to pediatrician, I think we need to, and as Mamta told, either we can have a nursing staff or somebody who can be well trained in lactation advisors and supporting mother for looking at this. So definitely they require more of counseling and more examination than any prescription. I think rest we had a good discussion over all those common cases that we saw across.
And most commonest things, madam, is like, day 1, day 2, when you just go for the round, ખાધું જ નથી હજી, પાણી જ શરૂ નથી કર્યું.
And everybody thinks that it's like a tap. They'll press and it doesn't come. They don't understand that colostrum is always going to be less. I think we have to deal with this and keep counseling.
Though at the time of delivery, I would have expressed 2 ml of colostrum. The same time in the OT table. After that also I had been told, આવે જ ક્યાંથી? કારણ કે પાણી જ નથી પીધું. આટલું બધું સમજાયા પછી પણ I don't know how to deal with that.
Now, and we need to really talk to our obstetric colleagues not to give them dabbas on day 1 and 2, especially C-sections. Otherwise, then they go home and continue that. Prevent this, because these days early discharges are very common. By 48 hours, they've gone home. So sometimes they have not gained the confidence of feeding the baby, and hence they come back with certain issues. Agreed. I think we'll have to continue dealing with this. It's no one short answer to those problems.
So there are 3 comments.
There was a comment. I just saw. Let me check.
This was
there was one that don't give antispasmodics to colicky patients.
Colic, yes.
Yes. There was one. Yeah. I think Ronak had commented. Agreed. Yeah. Colimax should not be used back and forth. Recently, I think I came across in Curious a trial where they have a particular brand of probiotic has been given over a period of 4 weeks and with placebo, and they saw some benefit. But infantile colic are always going to be.
I found good results in those patients, but it's over a period of time. It is for 28 days. Anyway, you are going to counsel the parents,
and even by that time, natural recovery also could have come.
You are going to counsel parents ki 4-5 દિવસ પછી જ ઇફેક્ટ શરૂ થશે, ત્યાં સુધી તો નથી થવાની, અને 28 દિવસનો કોર્સ પૂરો કરવાનો છે, એટલે anyway 28 days પછી એ સારું થઈ જ જવાનું છે.
Again, it's not as far as possible. I know many things,
but I found result in all the patients. 5 કે 6 માં try કરી છે, બધામાં મસ્ત result, બધા happy છે કોલેજમાં પછી.
Probiotics, I'm gonna manage treatment for the parents and not for the kids.
I really agree.
I'm very clear.
Only thing is, as a pediatrician, we should see that we don't miss a pathological cause.
Yes.
Yeah, like a preterm baby coming with hernia. On discharge, hernial sites would be normal, but can come at 6 to 8 weeks with an inguinal hernia. So we should be, as a clinician, ruling out a pathological condition before we label that it's just the colic.
Okay.
I think, Samir, we are...
Yeah. Over to Palak. And sincerely thank to Dr. Palak, our EOP Vadodara Secretary, for generously accepting to become the MOC of today's talk presentation. Thanks a lot, Palak.
Thank you,
Palak, over to you.
Yes, sir. I would like to thank Dr. Viraj Thakkar ma'am for taking a session very nicely, almost covering each and every point. Being a pediatrician, we usually deal with such issues. I just want to summarize in total. First is a breastfeeding jaundice. We should know all the red flag signs. Second was the infantile colic. We should know about that purple and also the red flag signs. The third case was regarding the regurgitation, and fourth was the feeding issue. Ma'am, I have only one question. Is there any role of a Proctectis drops for infantile colics?
Which drops?
Proctectis.
Is that the L rotary?
Yes, yes, yes.
Yeah, the studies has found that it is a good, but the dose and everything is yet not sure. But again, same effect, kind of a probiotic.
Okay. Okay, anybody wants to ask any question? Okay. Thank you, everyone. Thank you, all our experts, Dr. Sheila ma'am, Dr. Ashish Mehta sir, and our panelists, Dr. Jatin sir, Dr. Mamta Patel ma'am, Dr. Sandeep Tilwani sir, and Dr. Vishal Goli sir, for taking a part in this Expert Connect, a case-based discussion of AOPG presentation action plan 2025-26. Thank you all.
Bye-bye.
Thank
Yes.
you. Bye-bye.
Thank
Thank
you.
you all.
Good night.
Thank
Good
you.
evening and good night, everyone.
Good night. Good night. Good night.
Good night.